We're going to go ahead and start the lunchtime session. Feel free to go ahead and continue finishing up your lunches, etc. And I'm very pleased to welcome back to the podium Dr. Asirvatham from the Mayo Clinic, who is going to talk to us about newer anticoagulation trials.
Thank you very much. So this is, I think, a fairly simple summary of a little bit of history, then focus on the three main new anticoagulants we have available and the trial data, the high points of the trial data that we have to base decisions on, and then just a little bit on anticoagulants undergoing trials that we may have available or part of our decision-making process maybe in a few years. In terms of disclosures, really in terms of the drugs or trials on this talk, I don't think there's any relevant disclosure. So if we step back a bit, I think we have to remind ourselves that without question, whatever the other risk factors are, having AFib increases the risk of stroke. I think I have to remind myself of this sometimes, especially when you look at some of the ways in which we understand the powerful impact of non-AFib on stroke risk. And that's really why all that we know about preventing stroke, period, comes from the trials that relate atrial fibrillation and stroke. Warfarin, which we're most comfortable with, is a multi-factor or multi-target drug. And ever since its development at the Wisconsin Alumni Research Foundation decades ago, there's always been a try or a look to see at more specific targets in the coagulum cascade, and a few of them we're going to review. The key things to think about as we think about new trials is we can't question the benefit with warfarin. If at all there was a doubt, it was a doubt until maybe the late 70s, 80s, and then over the 80s and 90s, multiple trials that without question profound reduction in stroke in folks who had atrial fibrillation and risk factors with warfarin. Moreover, this reduction was an order of magnitude better than what we see with aspirin. And also things to keep in mind when we look at new anticoagulant trials. So clearly have a drug that works, and it works much better than aspirin in similar risk groups or settings for when we try to reduce stroke. The problem, of course, has been several things, but hemorrhage. And again, the very same trials that taught us how valuable a drug warfarin is in keeping patients free of ischemic stroke or cardioembolic stroke is the same trials that taught us how dangerous a drug it is in terms of fatal bleeding, as well as perhaps most importantly, intracranial hemorrhage. And we've tried to solve that historically by trying to get some risk stratification scheme that tells us a target population that's ideally going to benefit from the good of this drug, warfarin, and least likely to have the demerits or bleeding risks. But the stratification schemes, as you heard a couple of times in the early sessions today as well, are really far, far from being perfect in either of what they're supposed to do, either define a target population for intervention or define a population who's at risk for bleeding. You can get at this in many ways. One of them, which has always impressed me, is the overlap in benefit. In other words, when you look at the benefit of warfarin in various single risk factor groups that are studied, like big left atrium, persistent atrial fibrillation, and then you go back and look at a standard risk stratification scheme, you don't really see often a preferential benefit with warfarin, or a preferential risk with warfarin in one of these groups. Again, telling us that we may be able to identify risk factor schemes, but there's so much overlap, and this can be teased out when we actually look back at who benefited and who had the bleeding risks with warfarin. The key, though, in this problem or this lacunae in risk was the low-risk patients. Really, if you think CHADS 2 score of 0, as you saw earlier, that's still a significant risk. So one advance prior to the newer anticoagulants was risk factor schemes, most famously the CHADS-VASC score, that teased out this low-risk group and really identified a group of people whom you could say that you really aren't at risk. And I think this, in terms of comfort level for how we approach patients when we say bye to them in the clinic and we're thinking of not anticoagulating, how comfortable are we in that particular patient in saying that you really are at low risk? That changed, I think, when we think about a more structured or more advanced type of risk stratification scheme. We have to remember, and I think one of the lessons I got from the Danish registry studies was that it is a moving target. Patients with a particular risk factor score are not going to stay the same risk factor score through the years that you're going to care for them or they're going to be cared for by somebody else. For example, it's not at all uncommon in our patient populations to have, say, AFib affecting ventricular function, or the hypertension that gave rise to AFib may post-date the first time that you get atrial fibrillation, developing diabetes in these folks, worsening of a given risk factor. All of these make it hard to say what that risk is year after year, because we assume that the overall risk is going to stay fairly static, and it clearly doesn't in maybe about a third of patients, even with a decade of follow-up. Several other approaches have also failed historically, and why newer anticoagulants became such an anticipated option for us in treating patients. One, however, I think we'll probably continue to hear more about, and it's really quite a remarkable addition, I think, is cardiac biomarkers as either an incremental risk factor or a standalone risk factor for all causes of stroke, and in some analysis as an all-cause mortality in patients who are traditional patients whom we stratify for stroke. We also have to appreciate that we don't really understand what these risk factors mean. For example, one construct we have with AFib and stroke is the swirling around of blood in the atrium, left atrial appendage thrombus. But why these comorbidities, why these other risk factors make it more likely for that to happen in the appendage is not clear. We can say why hypertension will be a stroke risk factor, but why does it add to the risk that's bestowed by having atrial fibrillation? This is something I think which will get teased out better and discussed in one of the debates coming up later this afternoon. So warfarin, if you think about the key issues with warfarin that lead to why the newer anticoagulants are so helpful, I think it comes down to how it acts, its interactions, and it's multifactorial. It's kind of lack of specificity in acting in the coagulation cascade. We all know the therapeutic window being so important, and I think this is something the newer anticoagulant trials have taught in a way that we only kind of anticipated from previous studies. The importance of these therapeutic windows. It cuts two ways. First is no one or very few people over a consistent period of time stay in the therapeutic window. So even when we are using warfarin in what seems to be ideal situations, the actual staying in the therapeutic window where we minimize risk and maximize efficacy is much lower, I think, than any of us really fully understood. Drug interactions, all of us know from basically when we went to school, but the plethora of drugs, including drugs that are not prescribed, and their interactions has only grown in our understanding. I've recently had a couple of patients with drugs that I didn't even know that patients take, but major effects, either in terms of bleeding risk or other toxicity with the drug and warfarin. I think this is a major issue that's also something that's alleviated with the newer drugs. In our own minds, we understand these limitations, the therapeutic range, the need for monitoring, this relatively long time that it takes for for warfarin to go away or to get an effect. But it's one of those classic love-hate relationships. It's hard to come across, until these recent trials, it's really hard to come across a drug that was as effective or as consistently proven effective. Very rare to come across a drug which is that powerful and cheap, but you have all these issues that you had to look at, which I think every one of us it became something we wait for every time you go for a major meeting. Over the 90s, the 2000s, we waited for something to come through. And of course, we were often disappointed, especially in some of the earlier drugs. But if we think about how the newer drugs fulfill the criteria, we definitely want something oral, no question. We want something with predictable pharmacokinetics and pharmacodynamics. It should be a fixed dose. It should have a wide range or wide therapeutic window, reasonable cost, and definitely one of the targets was no need for careful or regular monitoring. The two targets that we're going to now focus on is thrombin, the direct thrombin inhibitors, and factor Xa. Now, both are attractive, both for the drugs we have now and future targets. Thrombin, really low down in the cascade. Xa, because it is a branch point for both the extrinsic and extrinsic pathways. Some theoretical advantages may be in affecting Xa rather than thrombin, because you're one step higher in the cascade, so you have to affect less of something that's already there. On the other hand, thrombin also has effects outside of the coagulum cascade, so good and bad, potential advantages or disadvantages of any drug that has a direct thrombin effect might be from this as well. Now, most of us remember the story here. This was really truly an anticipated drug. Everyone really liked, I think, the results. We were excited. You remember the buzz. And it was also a classic drug that kind of taught caution. And there are repercussion waves from this. When we learned about hepatotoxicity, and if you had a patient in your institution who had it, it really leaves an effect for a long time on how you approach a new drug that comes into this spectrum, into this market for a newer anticoagulant drug. How long do you wait after market release before you actually start thinking about routinely using a drug? Dabigatran. So I think all of you here know it's a direct thrombin inhibitor. It is reversible, reasonably rapid onset of action, and of course, the main thing that made it a landmark drug for study and trial was it did not require monitoring. It's truly one of the trials, the RELY trial, that changes how we think about a very common disease and risk reduction. So large study, which is also true for the studies I'll go over now. Remember that it was 3 arms, dabigatran at 110 BID, 150 BID, and warfarin dose adjusted to keep the INR between 2 and 3. Follow-up, median follow-up was 2 years, and primary outcome was all stroke and systemic embolism. Now, a few things about the baseline characteristics. I think the important things to keep in mind with this and subsequent trials was these were our patients, elderly patients with mean age of 71. The mean CHAD score was just above 2. You had to be 1 or above. You had to be above 1, and the mean was 2.1. Outstanding follow-up in the trial. And message number 1 in this was that in terms of non-inferiority, no question, with warfarin in preventing all strokes and embolization. And as we'll tease out, with the dose of 150 milligrams twice a day, there was benefit compared with warfarin in reducing stroke and systemic embolization. So putting it all together, it was not inferior to warfarin, specifically looking at 150 twice a day. There were less strokes and systemic embolism with dabigatran. The other side, which is important and will be a theme for the subsequent trials and trial designs, is what happens with major bleeding. And major bleeding, especially when you look specifically at intracranial hemorrhage, much decreased compared to warfarin. So if you summarize advantages, first and foremost, I think, which is true for the drugs we have now available, including dabigatran, clear decrease in intracranial hemorrhage, 150 BID decreased stroke, all causes of stroke, and it proved what you wanted it to. No need for INR monitoring. It worked fairly quickly. It was convenient. Patients and caregivers liked it, and you didn't have to worry about some of the most feared effects of heparin and warfarin, like necrosis and HIT syndrome. But there were issues, and these issues are important, and we'll go over them step by step, but mainly a little bit about dosing, side effects, especially dyspepsia. And I think to just say a little bit about dabigatran, for it to really work, it has to be absorbed in an acidic environment. And to guarantee that it'll be in an acidic environment, the capsule itself has tartaric acid, and this probably is why I think all of us who've used the drug have a significant number of patients. Trials maybe 10, 15%, maybe in practice a little bit more, that you actually hear this as a complaint in patients. But this dyspepsia, some patients, it's pain. The issues of interaction and anticoagulation reversal I'll cover along with the other drugs. And as with any new drugs, acceptance has to do with cost as well, and concerns that arise after the drug is released. And we'll go over both of these. So putting it all together, consensus and recommendation was it's useful as an alternate to warfarin in preventing stroke in patients who have atrial fibrillation and risk factors for stroke, and they don't have a prosthetic valve, they don't have significant valvular disease, and they don't have significant or severe renal failure, at least definitely not creatinine clearance of less than 15 milliliters per minute. Few things about the dosing. You remember that the trial had 150 BID or 110 BID. The approval was for 150 BID. It was kind of like a convoluted reasoning, as you heard briefly in the morning session as well, basically saying that, you know, the benefits were there for 150 BID. The reduction in intracranial hemorrhage was there for both the doses. It wasn't different between the two doses. So therefore, this single dose got approved. Caveat, a dose that wasn't studied, 75 BID, recommended if the creatinine clearance is less than 30. So the idea there was really just an extrapolation based on pharmacokinetic data to say use this if this dose, not a trial dose. Now, post-use, it's probably one of the most carefully scrutinized drugs maybe in history. And the concern all of you have heard about is this increase with myocardial infarction. Trend, not statistically significant. Subsequent meta-analysis, a lot of questions about the methodological design, bore out also this trend as such. At present, however, there's really no conclusive data. And if anything, the absolute risk, if we factor out the patient population characteristics who's getting the drug, and you keep other appropriate treatments still going for coronary disease, is very small. Couple of practical points also have become clear in terms of both concerns and risk. First thing is surgical management. You know, good rule of thumb is 4 doses. Missing 4 doses, it would cover 3 to 4 half-lives at least in minimizing the bleeding risk. Management of bleeding has been an issue, and important things to remember here is it is, of the drugs available, it is clearly significantly cleared by the kidney. Prothrombin complex concentrate is effective. It's usually effective within about 2 hours in terms of needing prior to a semi-urgent or emergent surgery. I'll talk briefly about the ablation issues as well. More than the MI issue, I think the concern was serious bleeding, which was reported in real-world practice. Again, you have to remember how carefully the monitoring has occurred compared to other drugs. But the stories that have come for this are the patients who are at risk are really the folks who are about a decade older than the average patient in the RELY trial, median age of about 80. Second is that it is difficult when you don't have the 110 BID option. I think that renal clearance is also a moving target. Often a patient is put at a 150 BID dose, and then maybe at the time that the bleeding is recognized, you go back and check, and maybe it was more appropriate to have a lower dose, and now the option we have would be 75 twice a day. So in reviewing this, the main risk factors that were recognized is prescriber error. Main error was not waiting for the INR to get less than 2 before starting the drug, not being cognizant of the issues related to renal impairment, or at least not following this as an issue longitudinally after the drug was started, care or excess risk in patients who were over the age of 80 or who were very small, and interestingly also folks who are very big. Remember that there were very few people at the extremes of body mass index that were recruited in the trials, either by design or somehow happened that way. And this is true also for the subsequent trials that we'll discuss briefly. So what about targeting 10A? Well, first of all, something I should mention briefly is there were two approaches that were used both for deep vein thrombosis, early phase 2 trials, and also for stroke reduction, indirect factor 10A inhibitors. What we're going to talk about, though, the ones that we're all familiar with, is the direct factor 10A inhibitors. Rivaroxaban, I think another landmark kind of situation or study. First, it's tried as a once-a-day direct factor 10A inhibitor. So one important difference there. Half-life ranges, but close to 12 hours in elderly folks. Unlike direct thrombin inhibitors that have an effect on platelet activation, there is no, and therefore on platelet aggregation, there is no direct effect on platelet aggregation, and relatively low risk for drug-drug interactions. Not zero, and I'll mention this in a bit. So another very large look, excellently discussed and conducted trial comparing once-a-day dosing of rivaroxaban versus warfarin. Endpoint for efficacy, looking at stroke and embolization. Again, in terms of non-inferiority, no question that this is an equivalent, at best an equivalent, clearly an equivalent drug to warfarin. And again, the same story, major benefit in terms of reducing intracranial hemorrhage. And I think I'll get back to this issue of the single place where there's, unequivocal that you can look at a newer agent or trial and show, well, there could be issues with bleeding elsewhere, maybe equivalent, maybe even more, but when we look at really risk of bleeding and specifically intracranial hemorrhage, clear reduction. Apixaban, also a direct inhibitor of 10A, 12-hour half-life, slightly on average, maybe higher half-life, excellent bioavailability, more than one renal as well as some hepatic methods for elimination. And the trial, the Aristotle trial, looked at 5 milligrams doses twice a day versus warfarin, maintaining in the therapeutic window. Very large study, double-blind trial, and looking at efficacy similar to our prior trials and safety of major bleeding. Little different in terms of the results here is that more than non-inferiority, there was benefit or actual reduction, like we saw with the 150 twice-a-day dosing with dabigatran in reducing stroke and embolization. And similar safety endpoints showing remarkable reduction in the chance of having intracranial hemorrhage. Just want to point out a few things in terms of the trials themselves for comparison. One thing to keep in mind is rivaroxaban, the inclusion criteria were such that patients who had a higher risk for stroke were included. So the average CHADS-2 score and the fact that you had to have at least a CHADS score of 2 to be included was important. This translates also in half of the patients, when studying rivaroxaban, had a previous history of some type of embolic event. So it was also high with the Rely and Aristotle, but half, little more than half, maybe 55% in when looking. So this may also, you have to keep that in mind when we're thinking about non-inferiority versus do we really have a difference when we say the drug was superior. The type of patient, the underlying risk for the patient was different. So if I summarize the recent trials, dabigatran, direct thrombin inhibitor, trial was 150 or 110 BID and warfarin. We have 75 BID for our patients who are with moderate renal dysfunction. Clearly, we saw superiority with the 150, non-inferiority with the 110 dose, and the main thing is the decrease in intracranial hemorrhage. Similarly, with rivaroxaban, once a day, 20 milligrams once a day, and it showed non-inferiority compared to warfarin, major decrease in the chance of intracranial hemorrhage. Apixaban, 5 milligrams twice a day, superiority in terms of warfarin, and clear decrease again in intracranial hemorrhage. Now, of course, when you think about comparing, you really have to have a head-to-head trial that's designed to compare, again, because there are major differences in the types of patients. But it's the best that we have, and I think if all of us understand the limitations of making indirect comparisons, but some themes come through. First is intracranial hemorrhage decreases. So that's the concern, either with the patient or you, and it often is when we're advising or counseling patients. Then going beyond warfarin to a newer drug, it really is a common theme that I think is hard to debate or question. In terms of the patient population studies, keeping in mind that overall risk factors were less with Rely and Aristotle, superiority in terms of reduction with both dabigatran at 150 BID and apixaban. GI intolerance, I think, clearly more with the dabigatran. Cost, acceptance, and that kind of heightened post-release surveillance just from the lessons that we learned from other drugs is continued and a factor for all three of these agents. Just a word in terms of other 10A inhibitors, all with some slight twist, either in terms of half-life, onset of action, or perhaps ease in trying to come up with a way to reverse the agent. Just some trials or drugs to keep in mind, the Explore trial with petrixaban, and probably more of you familiar with the Engage AF TIMI 48 trial. Duration of follow-up is similar to the trials that we just discussed. Endpoints are also fairly similar, but lessons learned in terms of what to do with the people who are at little higher risk for bleeding. You know, the elderly, very small, maybe the very large, and with lower creatinine clearance have been incorporated into these trial designs. Other approaches are also present, and some fairly exciting phase 2 type trials, including with inhibitors in the tissue factor pathway. Fundamentally different because they have a possibility or a potential to not only work as anticoagulants per se, but also affect some of the other risk factors for stroke. And happy to kind of review this briefly at one of the discussion sessions as well. One thing that's kind of intriguing is why do we have such a big improvement in intracranial hemorrhage risk. Kind of way you think about it doesn't make sense because other bleeding, not that much in terms of difference. Trials, even when you look at the people who had the best possible ways of keeping the patients in the therapeutic window, you see this. And it may have something to do with tissue factor expression in the cerebral cortex and the importance of factor 7. The importance of factor 7 for hemostasis is specific to regions in the body. It's about 3 or 4 areas. The most important is the cerebral cortex. And if you just avoid messing with factor 7, that may be all it really takes to try to decrease the chance of intracranial hemorrhage. Different for subdural or extracranial hemorrhage, and of course for hemorrhage in other situations. Word about reversal. Prothrombin complex concentrate, I mentioned. It is increasingly available and is probably, at least in our institution, what we've gone to both in the when needed in the ablation laboratory as well as for urgent surgical issues. For the overdose situation with dabigatran, it is possible to dialyze with the trial drugs as well, 10A inhibitor drugs. You think about overall efficacy and safety, I think it's really clear that we have effective drugs, and when you look solely at intracranial hemorrhage, without question, improved safety drugs. But at the same time, concerns grow, mainly because you get more used to it, you have surveillance, and we have to fine-tune to see not only with the drugs we have, but what the appropriate endpoints and trial design is for future drugs. And updating advice for prescribers, something the EP community is used to from post-market release of new devices or leads, how we keep up and how we keep updating. We also learned lessons from dronedarone, I think, on the importance of how a drug can continue to be available even though very serious subgroups of patients have serious toxicities that are recognized, and the way this can be communicated to a patient community directly and indirectly through a very large healthcare network. So right now, I think most practices, we think of it like this. Think about it, newer agents, clearly we have data to get it to that level. Some patients, some physicians, just doesn't make sense to use warfarin. Sometimes it's just a very clear patient preference. We've always heard that from patients. We've tried to manage that with things which we knew that didn't work, like using aspirin more of a little bit more than a placebo in some situations. Then remember, non-compliance is not at all an indication. In fact, non-compliance is more of an issue maybe with agents that we don't have straightforward ways of monitoring or reversing. So that is not a reason. So if anything is not a reason for thinking about making the switch, it would be non-compliance with warfarin. Big take-home point, I think, from the recent trials is how incredibly underutilized warfarin is in our eligible patients. And you just think about what that means. If you add how many people we just don't use it, or because of all these reasons, our worries, our concerns, legitimate as well as just a preference for warfarin. And then you think about how often we're not in the therapeutic window, and then you think about the discontinuation rate, you really have like a net population protection, the ridiculous amount of 11%. Now, it's still an issue with newer drugs, but it's at least heading in the right direction, even when you look into discontinuation as a result of side effects. So if I conclude, the conclusion is really questions. I don't think there are clear answers for, importance of individualization. I think that really clear understanding of elderly, small, creatinine clearance low type patients, appreciating that we still have to rely on risk factor schemes with the decisions that we make because they were used in the major trials that we have. Remembering that each of the agents available, really, we rely heavily on a single major outstanding, but still single trial to help us to make those decisions. Cost, societal impact, just getting analyzed and very different in different countries and even in different parts of the United States. And as we learn individually and as a community, how should this impact the design of future trials? And, my colleague at Mayo, Dr. Bernard Gersh, as a way of putting things, says in an editorial, clearly a therapy that removes many of the burdens of warfarin therapy. It's welcome, but for this to be really widespread, daily, not much thought, algorithmic type clinical reality, we have some steps to go through. Until we get all that together, we just can say the trials are outstanding chapters that are written, but story is still kind of not yet over. I'll stop there. Thank you very much for your attention.